Welcome once again to the session on digital engagement. Our session today will have three main parts to it. In the first portion of this webinar, we'll hear from Unicef colleagues with the health unit, and they'll be covering digital community engagement and potential applications for polio C4D, as well as digital health engagement and the vaccine demand observatory. And then in the second portion of the call, we'll hear country experiences. So we'll have colleagues on from the Philippines, Burkina Faso, Somalia, and Pakistan to discuss how digital engagement has been applied practically in their country experiences. And then at the end of the webinar, we'll have question and answers with the panelists. I invite you as the panelists are presenting to use the Q&A box in the bottom of your screen to write questions in real time as panelists are presenting. If it's a simple question, they might be able to respond writing back during the rest of the session. And any questions that remain at the end, we'll pose to the panelists live and be able to ask them live of them. So let's meet our speakers for today. We have Ivan Emezquita, the C4D specialist with the polio team at Unicef headquarters. Alex Mujereza, statistics and monitoring specialist for digital health with Unicef headquarters. And Angus Thompson, senior social scientist for demand for immunization with the health section. These three panelists will be in our first portion of the call. And then in our country experiences portion, we have Kathleen Solis, the C4D specialist polio with Unicef Philippines, Dr. Anik Sidibe, the head of communication health with Ministry of Health Burkina Faso, EPI, and Shah Jamal Akhlaq, C4D chief with Unicef Somalia, and Arifa Sharman, the communication specialist for media with Unicef Pakistan, and will present on Pakistan's experiences. So these are our panelists for today. Once again, I'd like to note for our colleagues who are now coming online, please be sure to select your language for interpretation by clicking the interpretation button and selecting your language. And if you have questions for these speakers as we continue, please use the Q&A box to ask questions of the speakers. You can include their name if you'd like a specific speaker to respond. Okay, so before we get started, we have a quick poll. If you look at your screen, there are two poll questions. So the first, we'd like to hear from you in order to see where you are right now in using digital engagement. The first question asks, which digital engagement tools is your office currently using? You can select all that apply. There are options from A to J, so 10 options to look through. And if you need the French translation, you are able to move the poll window to see the French translation underneath. And as you scroll down, question 2 asks, what is your biggest challenge in using digital engagement tools strategically? So we'll leave this poll up for another 30 seconds, and we'd love to hear from you. Okay, the poll is open for the last 10 seconds and we can look at the results. Okay. So let's take a look for the tools that you're currently using. Social media, 75% is the most common tool people are using, followed by U-Report and Rapid Report. And interesting to note that Magic Box is not a tool that anyone reports currently using. And for your biggest challenges, the top response, partnership with mobile networks to reduce costs is the largest challenge, followed by human resources and having local capacity available for this work. Okay, so that gives us a sense of where we are at the start of this work, and I'd like to introduce now Ivan Amezquita, the C4D specialist for polio, for his presentation. Thank you, Ivan.
Thank you, Erin. Greetings to all participants and panelists. It's really an honor to be in front of you. I'm keep seeing these names popping up in the list, and I'm smiling because I think we have many stories together. I think this is going to be another one. And for the ones who don't know each other, welcome to the C4D family and the C4D polio family. And thanks to Erin and to everybody for kicking off this wonderful encounter to share our thoughts and our experience regarding this big change in the way we work and the way we communicate and engage with our key audiences and participant groups. Let's go ahead with it to save some time for dialogue and keep this conversation flowing. Thanks, Erin. As you know, digital technology influenced the way to do communication and to relate each other since the last 30 years. If you can remember where we were in the 90s and getting your first Facebook account or YouTube channel, you will see how we tried to adapt as an organization towards those shifts at the time. And then it became really, really more important and more organic part of our way to do communication for development today. As you could also witness together in the last months of the year, a pandemic, as all the crises are an opportunity and an event to see how these technologies have to adapt to reach communities who may not always reach and access those benefits of communicating digitally. There's no free communication most of the time. And also how governments have to align and improve their capacities to the right sources of information. We will have in the webinar today countries who are really, really experienced to deal with emergencies, sometimes overlapping emergencies, and how to deal with the multiple sources of information that the public has, and how we align with the government and civil society to fill those breaches and to prevent misinformation and make our communication and community engagement more efficient. As you know, C4D also evolved during the last 3 decades, and now we have standards. I'm not going to get into that today, but I will remember that C4D and community engagement are being better measured than before. And all of those standards of quality are applied to this digital communication sphere. That's why we dare to put the digital community engagement in the title, and in a concept note that we developed in the unit of C4D Polio during the last months with the help of many people in this conversation and other units in the organization. Polio is looking forward to go to eradication and also to evolve in their way to manage C4D strategies in a more efficient manner and with more community engagement in different spheres. So this is part of this effort, and this is the beginning of a dialogue with country offices who are already operationalizing it to together learn how to make it more strategical and make UNICEF being in the niche of communication for development as it always was. So it's a lot to learn, and we will pass through this journey. Next, please. Next, please. I want to basically focus on what we sort of call a taxonomy of functions of different number of digital engagement platforms or tools that we just mentioned in the poll that we had the results with Erin. If we can rapidly group them, some of them are specifically useful for research, managed social data, and training. Remember, one of the standards of C4D is not just gathering the data, it's using them. So if the digital engagement tools are helping us to bring evidence-based communications to the community groups who are not exposed to evidence-based communication, it's really helpful, especially in these times. And we have a lot to learn in that function. Second, we have all this apparatus of public information and promotion that all our institutions try to improve lately. And this especially works for topics that are constantly needing demand generation, like immunization. Immunization, as you notice, is a dividing topic. So the only way to prevent misinformation and disinformation is to have the evidence-based trust information sources align and out as much as possible, any connections and reaching the demand of the most needed groups. This is a mix of having aligned the web pages for Ministry of Health with the Facebook page of a youth group or the WhatsApp network of a religious faith-based organization. It's challenging, and maybe it's a different, harder challenge like in the previous decades where we had to deal with big media corporations. Now it's multiplied, and we need to engage with all our teams, especially our social mobilization and community engagement teams on the field, to be part of the same human machinery, human face of all these digital spaces. And as you noticed more lively lately, in Polio, we had experience with this, addressing misinformation and even attempts of disinformation by groups opposed to immunization or health or governments or polio or a specific vaccine. It's becoming more and more important. And that requires to have a robust strategic setup in our plans and also in the capacities of our countries. Also, that implies human resources training and specialization. We will have many specialists in this call that we will get the names for and then catch up after. Especially we will have Angus, who is an expert in this. We have Alex Mujeresa, who digital health is investing in systems that are working pretty well, not just for emergencies, also for routine immunization. And last but not the least, and maybe the most important, as the poll shows, is the heart of our C4D work, which is to communicate and engage with people. Your report, Internet of Good Things are some of these tools that we know further and we know how to work better. I will, in the next pages, we can go inside of each one of these functions, but with not much detail, because you will have access to a longer document, a concept paper to comment and to contribute later on. So basically, repeating the functions, we can utilize digital community engagement for improving, gathering, analyzing social data, and especially using them. And I want to emphasize that. I will not go to each one of them in detail now. I will let that be part of the dialogue so we can move forward. Public information is a mix of our media machinery with all the institutional communication spaces and also the social media that are complementing it. If you can go to the Unicef webpage, you know which are the social media platforms that we use to complement them. And these are part of a big partnership, and this needs a lot of learning about control and especially taking attention of the feedback. This is big part and a challenging part of the strategic improvement we have to do. Next, please. We will have a special part in the panel to discuss tracking and addressing misinformation. And this is a big part of the debate, what we can do to address misinformation better, how we can prevent it or mitigate the negative effect of it better. And digital engagement strategies are called to be reinforced because of that, especially in times of crisis as we are today with COVID and with the recent outbreaks of EDPV2 in polio in many countries, especially in West Africa. We will know that and discuss that later on. Over. Next one, please. Community engagement is two-way communication, is how we utilize the digital engagement tool to listen and not just to get the data that fits our plans and objectives. An example is, for example, your report. Your report is a pretty strong tool that can be used for many things. But if we put too much weight on extracting the data, we will lose users. If we put too much into the engagement, we can open the discussion as much as we cannot manage it with the capacity we have. If we're utilizing as a public information tool, it also has limitations. So the balance among the functions are really important to learn, and we will learn from experience. And this is just an example of many we can use, and we will have opportunity to discuss. Next, please. This invitation, and now again, there is a concept note with the detail of all this learning we had in these months of the journey. And please feel free to comment us how to improve it, and we will put the outcomes of the discussion into this document. Said that, I think I'm out of time. I don't want to take more to invite for dialogue. And thank you, Erin.
Thank you, Ivan. Next, we'll hear from Alex Mujereza. Welcome, Alex.
Thank you. Thank you, Erin, and thank you, Ivan. Good day to everyone. I hope you can hear me loud and clear. If you could go to the next slide. So I'll be taking you through digital health engagement. And this is to look at how best do, within our health programs, cutting across immunization, WASH, MNCH, and the rest, at a country level, regional level, how do we adapt the various digital technologies in support for health system strengthening? Now, I understand that you could be aware of the digital health approach, specifically the one for UNICEF, among all the other approaches that are available. UNICEF has one which looks at the various milestones to be achieved, but also categorized around availability of services, the quality of those health services being delivered, the utilization of those services, how do we support accountability among communities, and how do we ensure the right information about services is provided. Let me know if my sound is okay. I hope everyone can hear me. So within availability, we look at supply chain management. We do, within immunization, we do a lot of vaccines procurement and delivery across the health system levels. And among those are a number of solutions that can support us in addressing these bottlenecks. Some of those based around the platform of Rapid Pro, information sharing on whether vaccines have been received, or temperature monitoring, or even how many doses data can be created, collected on how many doses have been disseminated or even given to children, using, for example, the example we saw in Pakistan and Indonesia. Then we also provide healthcare provider decision making. At the community health level, there are a number of solutions that can help guide community health workers in the diagnosis of, let's say, temperature of a child. If you're looking at training health workers or following up on the training, you could develop a quick workflow within Rapid that can always remind our community health workers on how they can capture temperature for a child. And so there are a number of solutions out there, some UNICEF-based, some with our partners, both at the country and regional level, that can support healthcare provider decision. There's also healthcare provider communication and client-client communication or targeted client communication, which looks at information dissemination among peers who might be health workers like yourself, or who might be clients and communication. On the client side, we've seen behavior change tools, which look at, for example, for pregnant mothers who are within the 1,000 days period and have delivered children. If you're reminding a mother to take their child for polio vaccination, you're able to share information with them on the benefits of the vaccination. You could send them a reminder to bring the child to the outreach center or the health facility. You could send a reminder to their partner to be able to provide the necessary environment to enable that mother to take the child. That's a behavior change tool, and it's available that we can support. Unicef has a number of tools that we work with to support that. Among healthcare communication, we look at tools which we have a number of categories on catalogs on frequent asked questions. If we've introduced a new protocol for a vaccination and we've trained health workers on that, we can provide a catalog of frequent asked questions where they can always pick new information on it and be able to understand how better to use it. For accountability, we are in a service delivery mechanism. We support partners and governments to provide services to workers. We need to be able to pick feedback from the end users or beneficiaries that we're providing service for. One, to help us improve the service, to help us know that the service has been delivered, but also, that as most of our donors require hold us accountable, or even hold us responsible for ensuring that there's accountability. And a tool like UReport, there are so other many tools that are within the health domain that are using the same model as UReport, some anonymous, some where you need to register these clients so as to be able to provide feedback. Lastly, we look at data collection and management, both individual tracking of records for our clients that we serve and for health workers. We look at data collection for the various services that we provide in support of the health management information system. We also look at, we've had, I think the best example here is the real-time information tools that we've looked across, and for also countries that are using national data warehouses like DHIS2. Also look at visualization and data analytics. So that in summary is the UNICEF approach, Victor Health.
Alex, for the interpreters, is it possible to move just slightly closer? The sound
Okay.
is okay, but just a little closer. Thank you.
Okay. All right. Great. Thank you. So, all right. Yes. So maybe this is so just to go on, in the approach, we get ahead to define the dictator-enabled health system, where we think this is where we see countries adopting technology solutions that prioritize reaching the most marginalized and vulnerable families with health information services and strengthening the ability of those health systems to collect, analyze, and use health data. This approach is envisaged around addressing the various health system bottlenecks. It's not the idea that you have, initially when we had introduced the digital health interventions, people are more of looking at them addressing problems like around, if I do not have information I require, can I adapt a technology that can make that information available? Now we are encouraging or promoting going beyond just looking at resolving a short-term solution. We need to be able to attribute the collection or the adoption of digital health technologies to addressing a health system challenge. If we're trying to make sure that vaccination services are closer to people, are within the communities, we are addressing the distance or mileage for people have to travel to access services, then we should be able to identify which opportunities that digital health provides or the health technologies provide to be able to address these challenges or bottlenecks. I would use the example of Pakistan again. They have a solution whereby you'll be able to, if you're they were proposing a solution to use WhatsApp to be able to make sure if a mother or someone is in a community and they are not clear on which is the nearest vaccination center, they could send a keyword via WhatsApp, and then they would get a list of vaccination centers that are nearby, and then they would identify which is the nearest, and they'll be able to access it. So that's one example that we could look at in addressing some of these health system challenges or bottlenecks. Next, please. Next, I'd like to touch on how we've utilized digital health in addressing the ongoing challenge of COVID-19 and how we've supported various countries around the emergency response. Of course, with the nature of COVID-19 having people locked up and making sure that services are being disrupted, especially particular health services, our main focus was around risk communication and community engagement, which was looking on how best do we, on the service provider level, how do we ensure that health workers are aware around infection prevention and control of COVID-19. So we supported countries to roll out or support two-way message communication, which may also known as chatbot. This is using technology to be able to have a two-way conversation with someone. This was via WhatsApp, Facebook, SMS, or even audio. Most of this content has already been generated and pre-loaded into the system and is being shared on what is COVID-19, what the various ways you can protect or prevent yourself from having COVID-19, what is the recommending social distancing, including all the information, all the authored information that was shared by Unicef, WHO, and other authoritative organizations. We built off existing digital health initiatives and ensured that, things like picking sample results, tracking on how they are picked, sent to the laboratory, tested, verified, and validated, and results sent back to the clients. All this, there are a number of initiatives that were able to support all this. Yes, Serene?
You have 1 minute left of the time.
All right, no worries, thank you. So there's been quite a number of solutions that are available around digital health, also that include in monitoring the supply chain. We mapped these solutions, and there's a link on how many of these solutions were mapped globally, and there's also guidance around digital health on how to use this. Maybe just to use this 1 minute to touch on the key considerations if you're thinking of adapting digital health solutions. Is you need to map if there are any partners in country who are using these solutions, who are already supporting the government or the country to adapt some of these solutions. What's the capacity within your country office and government to be able to take on a digital solution or even work with a platform, for example, like Rapid Pro? And then how can you use the various digital messaging initiatives to tackle risk and communication? There's quite a lot of support at HQ, at the regional office that can help you look at this. And then how do we have team discussions across partners to ensure that all health solutions are being deployed? Also make sure that the health workers have been registered and mapped across the health system levels, and we're able to know what are their capacity gaps and what we need to address as far as the scale of the digital health solution is concerned. Of course, not forgetting the various bottlenecks that these solutions will be delivering. Then we need also to be able to define our gaps or needs that require or that provide opportunities where these digital health solutions may be more helpful or more functional. Lastly, which is the last slide, we do have a digital health of community of practice, which is internal to only UNICEF staff because it's based on SharePoint, and the link is in the presentation. I encourage that you may join and subscribe. We do have monthly conversations around this, and we can be able to provide real-time support on how at any stage of digital health deployment or digital health that might be, or you might be. Do share any questions and I'll be happy to respond to them. Thank you. And our request, I think next is Angus to come in and make his presentation.
Thanks, Alex. Thanks, Ivan. Hello, everybody. I'm delighted to be here and honored to be following on from Ivan and Alex. I'll present today in English, in Australian English. I can answer questions later in French if you wish, but it's probably easier for the translators to translate my Australian English than my Australian French. Today, I'd like to give you an overview of a global or a project at HQ that I'm leading, that we've really just kicked off a couple of months ago, that we hope will provide broader support for all of your digital engagement activities. Before I present, I'd just like to highlight 3 key points for you to keep in mind as I go through my presentation. I've been working on demand for vaccination now for over 10 years, both in the social and behavioral research and design of behavior change interventions. And while we're talking about tracking and addressing misinformation, and that's something that I'll focus on today, it's important for us to, I think, bear in mind 3 key findings from the research. The first is when we look at the 4 modes of using digital channels that Ivan presented, the last one, two-way comms or engagement, is really something that we should be doing everywhere all the time. Push communications provide some support for people to find services, to know when they should and where they can access services, but they rarely have an impact on people's perceptions of vaccination and their levels of acceptance. So it's important that everything we do, and this is the opportunity of digital channels, be modeled around the idea of engaging with people. The second point I want to make before I start talking about misinformation and disinformation is that this is not the big part of the problem. The big part of the problem, whether we're talking about polio, new vaccine introduction for polio, the impact of COVID-19, introduction of a COVID-19 vaccine, the most important thing is understanding and addressing the questions that people have. People quite naturally have many, many questions around vaccination, and in times of pandemic, they have even more questions. And so everything we do should be focused on understanding that people have questions and we need to be able to answer them. And then secondary work is understanding the impact of rumors and disinformation. The thing I'd like to leave you with is, we know now that communications for vaccination can backfire, particularly in people who are already hesitant. So we have to test our content for efficacy and for safety. Okay, next slide, please. So I'm sure you've all been overwhelmed by the rumors, the disinformation, misinformation that's circulating during this infodemic, this COVID-19 infodemic, and that we've seen is drawing in immunization over and over. One of our partners that I'll introduce in a second has identified that vaccine critical messages have more than doubled during the pandemic, in English at least. In French, we've seen rumors circulate throughout Francophone Africa, rumors that have been fueled by doctors here in France, where I'm based. We've also seen misinformation or disinformation around promotion of different solutions, different products, etc. Just a quick point, I saw the comment from the translator. We don't have two words for misinformation and disinformation in French, but the distinction is important. Misinformation is false information that can be confusing for people. Disinformation is deliberately created misinformation that is designed to influence, to fool people, to influence people, and is designed by people who have ulterior motives. And I may get back to those ulterior motives later. Next, please. So, as Tedros said, we're not just fighting an epidemic, we're fighting an infodemic. And it's true that fake news spreads faster and more easily than the virus and is just as dangerous. But we also have to bear in mind that in these times of uncertainty, when we don't yet have a vaccine for COVID-19, indeed we don't have any solid solution, when we're looking ahead to introducing a new OPV vaccine, that there is also a need for us to be listening in and understanding the questions that people have, the sensible questions that people have, and answer those questions, be able to answer those questions. Next slide, please. We're developing a global program with the primary objective of being able to provide you in the countries with the tools, the guidance, the training, etc., to help you better listen in to the conversations that are going on in social media and mainstream media. But as I'll show you in a minute, to help you perhaps consolidate that with the listening that you're doing offline as well. The observatory has 5 large moving pieces. The first is focused on social listening and analytics. In a number of countries, people are using different social listening platforms. They're usually commercial systems that are, in my opinion, quite limited in their ability to access all channels. For example, I've never seen one that can access Eureport, and to analyze that data, because they're designed for tracking mentions of products. They're designed for Coca-Cola to understand what 13-year-old girls in Southern Australia think of their product. They're not designed for helping us to understand what's driving people's conversations and decisions around a health behavior. I'll come back to this in a minute in more detail. The second piece here is what we're calling a digital interventions lab. As I mentioned, content needs to be crafted and tested both for efficacy and safety. We're working with First Draft, who are experts, global experts in misinformation, with the Yale Institute of Global Health, who are a leading research team on the drivers, the social and behavioral drivers of vaccine acceptance, and hopefully with George Mason University, who are experts on inoculation against misinformation. And our aim will be to design and rapid test on digital channels content that we can then provide to you to be further adapted for your context. I'll come back to this briefly as well. But a social listening platform on its own is not very useful if we don't have people who are trained to use it, who are trained to do the analytics, to make sense of the data, to provide the insights in a format, in a way that our risk communication, community engagement, communications, advocacy, etc., is improved, is informed. And so we're working with First Draft to develop a training program, an online training program, to develop that specific competency. And we think that this will be probably more important than developing the cloud-based platform for collating data. I've got 3 more minutes. Where we will be working to mobilize and coordinate global partners through the Vaccination Demand Hub, but we'll also be providing all sorts of guidance on configuring the platform, developing digital strategies that incorporate social listening at this level. We're currently writing a misinformation management guide that will be available hopefully in the next 6 weeks, toolkit for M&E, etc., but also guidance that will help you think through who are the partners that might also need to be involved in any social listening strategy. Next slide, please. COVID-19 is touching immunization in 4 ways. Here I've got my eyes on routine immunization, but not only. First of all, we're seeing rumors, misinformation. I think that's pretty obvious. But secondly, through digital channels, we can potentially understand the impact of COVID-19 on access to services and, of course, provision of those services. And maybe to understand the impact on long-term demand for immunization. But the fourth key theme, obviously, is new vaccine introduction. We were initially focused on SARS-CoV-2 vaccines, but working with our colleagues in polio, we're now rolling in, weaving through everything we do, NOPV2 introduction as well. Next slide, please. These are the partners we're working with. I don't have time to go in detail, but PGP already have developed a social listening platform that is being used by 150 health departments, public health departments in the US. So they have the technical and operational experience. First Draft are leaders in misinformation. They work a lot with media and journalists, but also have training courses for the public, and will be working with us to develop that training course for the infodemiologists and Yale Institute for Global Health. Of course, we'll be working closely with through the Vaccination Demand Hub with partners such as WHO, Gavi, US CDC, and BMGF. Next slide, please. So I have 2 more slides and I'm running out of time. I won't go into this in detail. I want to highlight 2 key things in the tool that we're developing. The first is that we will be working to come up with ways of incorporating non-digital information into the system so that the analytics that we're doing of media, social media, and some of the more novel specific digital channels that we have or digital tools that we have, such as YouReport, we want to be able to add community feedback, for example. That's the first thing. The second thing is that we will be working with real experts to develop algorithms that will allow us, hopefully, to really start to make sense of the data, to visualize that data, but to go beyond basic sentiment analyses to in-depth social network analyses, understanding of intentionalities, and perhaps online and offline behaviors. Next slide, please. And that tool will be made available. It will be a tool that we will aim to be able to tailor for each country's context. I don't have time to go into this today. The WHO Infodemiology Conference identified a fundamental need to develop a new function we're calling the field infodemiologist, that person that I discussed who can do the analytics, who can do the listening, who can provide the insights, who can support the M&E, etc. And we're working to create the training to start to develop these unicorns, as one of my colleagues called them. Next slide, please. So this is my last slide. I'm going to spend 30 seconds and then I'll stop. It's very important, and so we'll be pushing the idea of an operational framework that really pushes the development of strategies that have this kind of virtual cycle of listening, detecting signals, doing the monitoring, visualizing the data, understanding, making sense of the data through analytics and what we might call intelligence, because that's what informs all of our actions on the ground, whether they're in digital or non-digital channels, but also implementing measures. And this is one of the advantages of digital channels, so that we do this, we know what's working, we know what's not working, and we continually improve what we're doing. And I think that's my last slide.
Thank you so much, Angus, for your interesting presentation. Our next session will go into the second part of our session. If you have any questions for Yvonne, Alex, or Angus, please find the Q&A box in the bottom of your screen and add your questions there, and we will ask the panelists at the end. As we're going into our country experiences, we have another poll. If you take a look at your screen, we'd like to hear from you about what you are most interested to hear about from the next presentations. So the poll is open and you can cast your vote. The speakers will be discussing each of these topics. So we'd like to hear from you what you're most interested in. Whether it's the challenges they faced, the things they tried that worked well, the things they tried but they did not work well, the support they think they need going forward to address challenges, and what their approach was for strategically applying digital engagement for the polio program. Okay, so let's see what our results were. If you look at your screen, you can see the results. People are most interested in hearing about what worked well, followed by strategic applications. So we look forward to hearing how this applies in the various countries. So first, I would like to introduce Kathleen Solis from Unicef Philippines to discuss her experience.
Yes, hello everyone, and thank you for the opportunity to share our experience in the Philippines. Just this month, we initiated our digital campaign on immunization using Unicef social media platforms, mainly Facebook. We call it Community for Immunity to send the overall message that immunization is a shared responsibility. Next slide, please. In the Philippines, the immunization coverage for all vaccines has been declining from 80% in 2008 to about 70% in 2017. In 2018, there was a major controversy brought by the school-based dengue vaccination program, wherein the vaccine was linked to the deaths of children, some children who received the vaccine. Although there hasn't been any conclusive evidence to prove this, it caused a decline in vaccine confidence. It was highly politicized and it made headlines. And in 2019, the DOH declared that polio is back in the Philippines. And so an outbreak response in selected areas of the country was launched, and this is still continuing in some areas. So right now, COVID-19 cases continue to increase in the Philippines. We have the highest number in Southeast Asia, and quarantine restrictions are being implemented in selected areas. Health personnel are overwhelmed and health facilities are struggling to accommodate patients. Immunization services in some areas were disrupted because of the pandemic. Why did we, next slide, why did we decide to come up with a UNICEF branded digital campaign? We would like to complement the efforts of the government in promoting immunization, especially at this time when government personnel are so overwhelmed or overstretched. The Department of Health is also facing trust issues. We would like to use our platform to amplify messages and, more importantly, to lend UNICEF's credible voice in the digital space. Aside from that, Face-to-face engagement are very limited, so we want to maximize social media to reach audiences, although reaching those who are not digitally connected remains a challenge. We want this digital campaign to be able to help increase knowledge of vaccine preventable diseases, increase risk perception, confidence and trust in vaccines, and promote shared responsibility. What worked well? We just recently started the campaign. So coming from both our ongoing and previous digital initiatives, we think that the engagement of celebrity influencers helped us a lot. We have 3 goodwill ambassadors, and all of them have a huge following and catering to specific age groups. Interactive content also works, and having a clear call to action, making sure that we provide a content that people would love to share with friends and relatives. And then people seem to like basic content, as basic as a schedule of the routine immunization, and also presenting information in Q&A formats. Next slide, please. What hasn't worked, or some of the lessons that we have learned so far? One is that our strategy needs to be agile enough to be able to adjust to the evolving situation, just like what we are experiencing now in the Philippines. We think that we need to better explain why we are saying that immunization is a shared responsibility. While it is the main responsibility of parents to make sure that their children are immunized, we need to explain better that it actually takes the whole community to protect children from deadly diseases. So some of the issues and challenges we are facing right now include the trust issues facing the Department of Health. We are seeing a lot of anti-vaccine sentiments. Many of these are related to people's trauma from the dengue vaccine controversy, which makes it difficult to promote injectable vaccines. There's also a wealth of content now catering to the needs of different people. There is a need to stand out and catch people's attention with our content and satisfying their information needs. And we are challenged to be more creative and innovative. So in this way, it is a good thing. The key area where we would need more support is on M&E. This includes the need for quality user analytics. We'd like to better understand our online audience, their behaviors and interests, for us to be able to tailor fit our content and tone. We are trying to figure out how best to demonstrate the contribution of this digital campaign to the bigger efforts led by the government. So for example, in the ongoing polio outbreak response, which are implemented in specific regions, we are targeting our FB ads in these regions. It would be great if we can demonstrate how we are able to contribute in achieving the targets in these areas. So we need to show strong linkage and in sync with field level activities. So any good practices on this would be very useful for us and highly appreciated. So I guess that's it as an overview of our experience in the Philippines. Thank you very much for listening.
Thank you very much, Kathleen. If anyone has questions for Kathleen, please enter those into the Q&A box. Next, I'd like to invite Dr. Anik Sidibe to present on the experience in Burkina Faso. And please note, Dr. Sidibe will be presenting in French. So again, if you'd like to listen to the interpretation in English, make sure you select English by clicking interpretation. Welcome, Dr. Sidibe.
Merci beaucoup, Erin. Merci à l'UNICEF.
Thank you, Erin. Thank you to UNICEF for giving me the opportunity to share our experience. In Burkina Faso, this is the first country to have realized a immunization campaign in the context of COVID. Since 2016, the Burkina Faso did not realize any campaign against polio. And in January this year, in 2020, we experienced the outbreak of polio in an area close to the border. We could realize the first round of response to the outbreak before the outbreak of COVID in Burkina Faso. We could not realize round 2 because we detected the COVID in March. So we had to postpone our campaign in July 2020. With the outbreak of COVID, like in other countries, we experienced the emergence of a lot of fake news about immunization, a lot of rumors against immunization, and it led to a diminution of immunization. So what did we do in terms of digital engagement? You have to know, first of all, that not like the rest of the countries where there is digital engagement since a few years, yeah. It's only, we have a very recent presence, a digital presence about immunization, only like 1 or 2 years ago. So we are trying to reinforce this presence online and on social medias. So what are the tools that we use in terms of digital engagement? We use a lot of social medias, Facebook, WhatsApp. Those are the most used in the country.
Dr. Anik, could I ask for the interpretation? Would you mind slowing the speech down to help the interpreters? To speak more slowly, please.
So we also use web pages. The Ministry of Health has a specific web page. We also have blogs from influencers of the country that we use when we share some information about immunization. We also use platforms, YouReport, ODECA. Also, we use texting to spread more information, and the call center that we are using since the outbreak of COVID-19 in Burkina Faso. Regarding the immunization campaign, I will spend a bit more time on our experience since July, when we had 100% cover for immunization. Those are the data of the investigation. So what did we do in terms of digital engagement? We first of all announced the coming of this campaign. Like 10 days before, on the social medias, we spread all the information about the campaign. We spread a call for religious leaders to raise awareness about immunization. We also started a mechanism to monitor rumors. And during the campaign, we continued to spread out messages through texting, through social medias, several messages. We monitored the campaign with the ODK tool. And finally, we established WhatsApp groups that allowed the managers of the campaign to be in constant communication with all the agents on the field. Next slide, please. Thank you. So what were our challenges? I was glad to learn that there are tools to monitor the conversation about immunization, because we had a lot to monitor those discussions on social medias, so we could follow them, follow those rumors. Also, we have a bit of lack of human resources capacities. Also, another problem, the delay in responding to misinformation, which is pretty big, because maybe we lack of training, a lack of strategy, a response strategy to the rumors on social medias. The main bottleneck for digital engagement was, of course, the insufficiency of staff with capacity in digital engagement, but also the availability of internet connection in all the places, all the public services engaged, committed in the campaign. And also all those rumors on the social media that were quite a challenge. Next slide, please. So what are our needs? Well, it depends on the challenges. We need more training in digital engagement and remote monitoring. We need specific message that are already made and ready to be spread out on the social media. We are talking about our capacity in terms of design to share content adapted on social media. Also, increasing the web presence of the office online on Facebook, WhatsApp, internet, and of course the webpage of the Ministry of Health. Maybe your report platform could help. Maybe we could increase the communication on this platform because it's already quite working. So that would be a gain for us. What type of strategy in terms of communication should we need for polio, in polio response? We've seen that we have a reinforced monitoring for digital platforms. We also noticed that there is an awareness through a certain public, so a certain audience, the audience on the social medias, when there is right digital engagement. It's the same for influencers, on social medias, on blogs, web pages, and for crisis response. Thank you. Well, last slide. It's showing you a bit of what is the content we spread out on our pages. Thank you for your attention. Now I'll let Jamal speak.
Thank you very much, Dr. Sidibe. Now we have Shah Akhlaq from Unicef Somalia. Welcome, Shah.
Thank you, Eddie, and welcome to the presentation from Unicef Somalia Country Office. So we are going to share our experience in going paperless using ODK for COVID-19 response. Next please. Yeah. So first of all, I would like to say that it's not that we decided to go paperless and we did it. It's rather the context of our country office that actually wanted us to go paperless. So what was the context? First thing is that the Somalia is one of the bigger country program in Isaro region with a smaller RCC budget. And we didn't have adequate HR to do a lot of paperwork, collecting and those things and analyzing things. We didn't have the human resources. On the other hand, we had in-house expertise within UNICEF and within the RCC pillar organization, including myself. And then there was frequent reporting requirements as it happens in all emergency contexts. So these are the things that actually suggested us to go for ODK-based intervention and to go paperless. So once we do that, we come up with some very good experience. And what was those experience? First of all, it saved a lot of time and cost, and it was suitable in COVID context. Particularly in COVID, the situation changes over time very frequently. For us, it was needed to have the real-time data and analysis so that we can decide accordingly. So it was fit for the purpose. And at this moment, I can say that the ODK that we are using in Somalia became lifeline of our RCC intervention. And it requires, one of the things that was challenging to some extent is that it requires much capacity building. And the good thing is that it created a data mine. I mean, a lot of data we could generate, and there was an endless scope of analysis. And that the thing that we personally very much appreciated is the real-time data. Whenever things happen, we get the data immediately, and it was analyzed immediately, and we have the analytic dashboard immediately. So these are the good experience, good things that really helped us a lot. Next please. Okay, now what are the areas that we brought under this digital engagement? There is broadly 8 areas which was covered through this initiative. And like, for example, national level RCC planning and coordination, we used primarily online based templates. For intervention tracking and reporting, we use ONA based ODKs. For rapid assessment, we also use ONA based ODKs. For remote tracking, we use also Rapid Pro based Rapid Pro and combination of Kobo and ONA. Actually, we use multiple tools, and we also use ODK for remote tracking, community feedback. I'm not going to that detail, but what can I say that we use ONA, Kobo, UReport, Rapid Pro, and beside Facebook and Twitter. And for analyzing, we use basically one application, that is Microsoft Power BI. And all our ODKs was platform independent, which means that it can be used in any digital devices, be it Android or Apple based device, and it can be also used in Windows devices like laptop and desktop. So next please. Yeah. So now what worked well? First of all, the thing that worked very well for us is the sound ODKs. Most of our ODKs was right first time. We did not have much bug, and we did not have to redo things much. So it actually worked from the very beginning, and it provided us real-time data analysis that I mentioned earlier, and it effectively helped us in tackling and reducing infection and fatalities. By the end of May, we actually use almost all of our ADKs, and which are continuing till now. And if you see the scenario of Somalia, we have reduction in infection and fatalities from the beginning of June. And it also facilitated us in informed decision making. And next please. Okay, so one of the challenges we had is that limited fund, and even the limited fund we have that were shorter in duration. And then when we started this intervention initially, our people in the field were reluctant. They were more comfortable using the paper-based system, and there was a lack of capacity in the ground in using the ODK-based applications. And also, whenever we wanted to train them, one of the big challenges was that due to the COVID and social distancing things, we could not actually organize face-to-face training. So most of the training we conducted for capacity building, for this reason, it was basically through online. I mean, through Zoom and Skype for Business. Next, please. Okay. Okay. The support that we need is that adequate fund with a longer duration. We need fund, and also we need the duration of the fund so that we can spend. And one of the key contributor in our paperless ODK-based RCC intervention was a regional social mobilization coordinator and district social mobilization coordinator. We really wanted to keep them until the end of the COVID response, and that's the support will be needed. And also in order to reach
De plus,
our special groups, like we have a lot of nomad population in Somalia. For that, we are extending our partnership with Ministry of Livestock. And for better ODK and better, one thing I forgot to tell actually, in terms of intervention, we are using interactive SMS, voice SMS, and interactive radios. And with support of WHO, we are also having chatbot. So for all these things, for digital content development, we also need to involve third parties. So some help on that will be also helpful. So in terms of collaboration with the polio program, one of the big problem we're facing now, we are short of human resources. So and technical assistance at the specialist level will be very helpful. We need to continue our social mobilization network, and the integration of COVID-19 messaging during the polio campaign that we are planning in the second half of the year will be very helpful at the same time. And we have partnership with the National Islamic Advisory Group, but we can there is a scope to better utilize our collaboration with them. So these are the areas we have the scope for collaboration with the polio program. Next page, please.
Thank you so much, Shah, for your presentation. If you have questions for Shah, please write them in the Q&A box. I see there is one there already. For our final presentation, I'd like to invite Arifa Sharman, the Communication Specialist for Media from Unicef Pakistan, to present on their country office's experience.
Thank you very much, Irene, and good afternoon.
Merci, Irene. Bonjour à tous.
Can you hear me clearly?
Yes, you can continue yes.
Thank you so much.
Merci.
I am presenting Pakistan Polio.
Je vais présenter le cas du Pakistan.
The interpreter, excuse me, is in the English channel rather than French. Okay. Please continue, Arifa. Apologies.
So I will present Pakistan Polio Eradication Program social media experience. Here we have the Pakistan. Can you go to the next slide, please? Pakistan Polio Eradication Program started actually the social media engagement in 2013, but due to the program priority, program actually wants to maintain low profile due to the country situation. And in 2018, actually, the program decided that it should take a proactive effort to engage in social listening and engage with people more by interacting with them. So in 2018, the whole social media platform boosted up, and we had we have now a team of group of people who are working full-time on and managing this social media platform. If you see the context of social media in Pakistan is now the increasing trend. We see the 10% per year, the user increasing trend, then 80% internet. 80% users are using internet via mobile phones. And for if you see the platform of the social media that we are using here, people are using, actually 41 million people are using Facebook. So Facebook penetration is much more higher than any other social media platform. Twitter is also very active here, but Twitter is mainly used by policymakers, educated people, and also the politicians, so they are more active on Twitter platform. And if I see, tell us our PEI social Facebook followers, now we are actually close to more than 350,000 followers. Just today I saw, and we have also more than 10,000 Twitter followers. So that is the context we are working. So one of the important things that what is really working well, we are trying to building positive narrative over anti-vaccine propaganda, because in the Pakistani context that is a big challenge for us. So our content that we are creating is more user friendly, coming from the provinces, both in Urdu and English, and we have also provincial Facebook pages. So we are also doing content integration. And one of the important thing that we are using for developing our content is social listening and engagement. How we are doing this? We are using sentiment analysis. So in Pakistan, every week we are doing this sentiment analysis related to polio. We see whether it's going up, going down, and what are the factors actually creating this sentiment. And those information actually we are feeding in our content development process. The other thing that really work well is mapping of influencer and engaging them in content creation as a neutral voice. And they are posting those content on their own Facebook platform or social media platforms. And we are reposting to those content to our PEI social media platform. Partnership with Facebook was really helpful for us because that we use this partnership for two different purposes. One is boosting a specific post, focusing on a specific geographical area. Another is that handling this fake news, because in Pakistan this is a big issue, and vaccine hesitancy, fake news, rumors. So those that this partnership really helping us to build, to really tackle that challenge. And I think all those things is helping us to contributing to building the trust among the community members. So the thing that did not work well, that one thing that we said, the YouTube, because most of the time we have seen that negative news is coming from YouTube or Twitter. It's more propaganda, and most of them, these are generated from outside Pakistan, and then they are this anti-vax group actually using them in the context of Pakistan. So curbing that is really one of the difficult challenge for us. Digital divide, many parts of the world, we are also facing the same challenge. And content sharing through community engagement and activities is also another issue, because we are planning, we are doing that, in limited scale. The content that we are developing for our social media, those content have really good engagement. We want to share those content to our field mobilizers, so they can use in their group meeting, community meeting, as a influencing factor, opinion influencing factors. So this is one of the thing that we are aiming to further extend. Then another issue is tracking anti-polio propaganda, which is and also resurfing the old post. We have excellent mechanism to monitor anti-vaccine propaganda. Every day we are generating reports. But the problem is, most of the time we found that as Facebook has its own standard protocol to block posts, so most of the time we have seen that they actually limit some posts. And when we have, and those posts, those are limited, those are again resurfacing. And every month we have, like, on an average 20 to 30 negative posts on Facebook. That is one of the challenges that we are facing. Another issue is women's access to the social media is still very limited, because you can understand the context of Pakistan is very much religious, and also social media or the phone, because if you see, I mentioned at the beginning that most of the people are using phone for the social media surfing. So women really don't have that access that much. So can I go to the next, please? So when we said what kind of support we needed, we actually want to establish collaboration with YouTube and Twitter to especially blocking and deleting those anti-vaccine propaganda, because it's resurfacing and coming back several times, and whenever they got opportunity they use it. Then another is experience that we have seen, that animation works very well to reach to the people here. So we have limited capacity on that, so we seek technical support for making more animated content that really connect people. And another issue that support that we really want is alert. If there is any kind of alert system we can really use to inform the country office that this is coming up, this is happening, because most of the cases we have seen that negative anti-vax propaganda is coming from West, and that is replicating here. So if we can establish some kind of alert system and we know earlier that this is coming, then we can also organize ourselves better. I think that's the thing, and that's the thing from my side. And sharing, what is this? This is, I think this digital experience is more nowadays coming up more to engagement with the social media when you're working with the social media team, and also community engagement. That's a more link with that, and we are bringing the voice of community people through video. That's really we found is very useful and helpful for the for making our case and creating a positive environment for vaccination. So I think that's from my side. And one important thing, sorry, I missed that, you know, we are using also WhatsApp channel, which is really our community mobilizer, they are using phone, and most of them have this WhatsApp access. So we are creating specific content and sending to them also to use those content to reach to their community members and influencers that help them to really manage the challenge of vaccine hesitancy. I think that's the things from my side. Thank you very much for listening.
Thank you very much to Arifa and for all of our presenters today. We really appreciate having the ability to have this forum to bring everyone together and to hear from these experiences and learn from one another. Next, we will go to the question and answers. We have a number of questions that have come in writing, and we'll share out afterwards the written questions and the written responses. For now, I would like to invite you to, if you would like to ask a question out loud of the panelist, please raise your hand and we will allow you to ask your question. And after we take a question out loud, one or two questions out loud, for the interpreters, there is a question written in French in the Q&A box, and we will go to that next. Okay, so as we, please, I invite if there's any questions to raise your hand. And as we are waiting for that to come in, let's go to the question in French for Annick.
The question in French is, so Annick, the different digital channels have been very well used because the result has been almost 100%. And so I would like to know if, based on these results, if at least 95% of children were vaccinated during this campaign. Thank you.
Thank you. The administrative data is 90. Sorry, I'm going in English.
You can answer in French, it's fine.
En fait, la couverture vaccinale nationale est de 90%.
So the national vaccination coverage is 90%. And when we did this independent monitoring,
we noticed that we did not find any
non-vaccinated children.
So there were no
refusals.
Of immunization. So why do we have a
lower
why
this
immunization cover? It's because
coverage
the objective was
lower. It's because some children were already vaccinated. Some the last campaign was in 2006.
So we want, so the data is not reliable. So we wanted to
added 10% to our target,
increase it,
and so we also reached.
Thank you.
Children that were not present in the country at the time. Thank you.
Thank you, Annick. We also have a question for Arifa for the Pakistan program.
Yes, I have already answered. One of the question was on the engagement of religious leader. Yes, we are working very closely with all religious leaders, both at national, community, and provincial level. And if you see our social media posts, you will say every alternative day we have some post, and they are verbal, kind of commitment and encouragement for vaccination. So they are really working very well with us. But interesting thing that if you see that comments that we receive on those kind of posts, like if I see that 500 600 comments we receive immediately when you post those kind of religious persons conversation on the polio, among them maybe 30% are very negative. So we have to really delete those, or not delete, actually we hide them. And sometimes we also request other colleagues to really answer those kind of questions, which are really more practical. So that is the way we are handling that part. So there is other question I can see that, medical using, what about the past UN professional or media consultant? We are working actually at different level, engaging different people from different capacity. So it's not that we are not doing this. The thing is that my presentation was very much focused on digital media. So that's why I did not talk about those parts. Thank you very much.
Thank you, Arifa. We have a question from Shahid Awan. You are unmuted and had your hand raised. You may ask your question now. And next we can go to Rohi.
Yeah.
Yes, we can hear you. Yes, it's a little faint if you could speak up.
Okay, so my question is for Arifa. I just wanted to understand the most problematic area in Pakistan is Peshawar, and the digital literacy rate is quite low in the problematic area. So how are they addressing Peshawar?
Thank you for your questions. This is something really challenge for us, but in KP, what happened that we try to use local channel to disseminate those messages. That is more, community engagement and local C4D activities. They have the different device they're using to reach those people. But if you see, the limited access of internet is still there. So KP has its own Facebook page, and they have their own community also. They have their own language. So those kind of things they're handling by that Facebook or social media platform. And certainly another issue another area that we are working is WhatsApp. So the phone is still there. People are using cell phone. So important message we are sharing through WhatsApp, because our social mobilizer, they have their own connection. So if I share one message to one social mobilizer, that social mobilizer send that message to those people that she or he is working. So that's the way it's replicating and sending the message. Certainly, this is one of the big challenges for us to work in KP because of the various reasons, and especially those areas that security compromise area. There we have really limited penetration of social media. Thank you.
Thank you, Arifa.
Thank you.
Thank you, Shade. So we are now at 30 minutes past the hour, which is the time for the webinar. We do have more questions coming in, and a few of our panelists are able to stay on. So we can continue for about 10 to 15 minutes for those who would like to stay. For those who need to leave at this point, thank you so much for your participation. As you are leaving the webinar, you will see a survey. You click continue. If you'd like to give feedback on the session, we'd love to hear from you. And panelists, thank you very much for your presentations. If you need to leave the call, thank you so much. And if you'd like to stay on, we'd love to hear from your expertise. If you wish at this point, you can use your video as well. Next, we have a question from Rohi. You are able to unmute now.
Thank you very much, Erin. And thank you very much, Ivan, for that wonderful presentation where you talked about digital community engagement. And it got me thinking about traditional communicators, because I know in digital community engagement, most often we focus on social media. But now those traditional communicators who, for example, in the rural areas, those who cannot even access or even afford social media platforms to get there, but then they have their own traditional focal points or institutions through which they also trust within themselves and could be as a platform for community engagement. And also it could be sustainable for them. So I was thinking, how can we digitalize traditional communicators? Because I think it is often not much explored, but I think that your concept note, if we can look through it and feature it there and also explore it, so that it could be an advantage, and a very good experience in our polio C4D programs. Thank you very much.
Erin, I was meant to leave, but can I quickly add a comment?
Yes, please.
So I mentioned, in one of the questions that I answered, I mentioned that in a previous life, I developed a social media 101 training course for healthcare professionals. It's not a heavy lift to train people who are not yet in social media to get into social media, to become comfortable with it, and eventually to build influence. And I think going back to comments that we saw earlier on about the importance of trust, this can be often a really valuable investment. If we can get more trusted voices into the online conversations and provide them with the support to increase their reach and support through content, we can potentially have, I think, an impact on the tenor of those conversations. So that training course is being rolled out currently with the International Pediatric Association, but we can always have a talk to my previous organization and the IPA if we think that that would be a useful tool, a useful training for use across countries. I have to go now, but thank you all very much for your time, and I hope that this was interesting for you. Au revoir.
Thank you. Would any other panelists like to comment on the last question?
I can make it in a minute. That was a really good point and was really present in the discussions during COVID time and digital engagement strategies. How to digitalize traditional communicators is one of the areas that we can improve strongly and invest. Those traditional networks need also us and needs to learn how to do this better. And as UNICEF is usually present and recognized voice, it is a special bridge for trust building. If a religious group, a women group, or a youth group are developing their own platforms, easily can hook up with some of the platforms we are already building and our partners too. We need those partners or those voices to maintain the alignment of the trusted information and to also inoculate them against misinformation. And this is a good capacity building challenge for C4D ahead. Thanks.
Thank you, Ivan. Next, excuse me, yes?
Rim, can I come in for a second?
Please.
I also wanted to add that on the tool side, it would be there are quite a number of demonstrable examples we have for social media options. That is, if we find that there are groups due to reasons of either infrastructure or phone ownership can't access social media, there's possibility that we can translate these groups over to peer group communications, either on SMS or using audio, as other countries may have used VIAMO. And we can always discuss and explore more how we can do this. Thank you. Over.
Thank you. So we have next a question from Muda Bas. You should be able to unmute and ask. Yes, we can hear you.
Yeah, thank you so much for the wonderful presentation. I have a question with my colleague from Pakistan with regard to reaching out to the females. I was going to the presentation and I've realized that the female has a very little access to the digital platform, including social media. and they are the most important in terms of reaching out to for the polio messaging. And considering the amount of resistance we have observed and seen in Pakistan, how do you effectively reach to these females with the polio messages? Thank you. Over.
Thank you for your question. It is really, really a challenge for us also, because you understand the Pakistan context is really very conservative, and still the most of the family headed by man, and the control over actually based on is man who is controlling everything, most of the cases, right? So, and the education also, if you see the education level also very low in terms of women. But the thing that our C4D colleagues, they are using actually the social mobilizer from the area, from that community, who are the first line of contact with this female household or the female member of that family. So that's the way we are helping. But another interesting findings, actually, I was reading in one of the observation that when a child grow up, like is going to school, and they have not, if they get access to the cell phone, so then mother also get that access to the cell phone. So this is also this kind of experience we also found in our helpline that we are managing for polio program. They are often 13, 14 years girl or boy, in most of the cases, called and said, my mom wants to talk with you on this issue. So that's the way it's happening in the reality. But as I said, that our first line of contact is our social mobilizer, female social mobilizer from the community, reaching to this woman. Thank you.
Thank you. So we have, would anyone else like to comment, another panelist on this? Or we have 1 to 2 more questions in the question box. Next, we will take a question from the Q&A box. Which of these online tools for social listening would be suitable for basic phones? Do we still have a panelist on that would like to respond to this?
I briefly can comment as more detailed in the concept that UNICEF work with Internet of Good Things, which is a technology utilized and designed for simple phones. And that can be touching some of the functions that we discussed, not all, but it is in the concept we have specific examples how to utilize this for polio C4D, for example. And yes, the technologies are taking this consideration in their strategies to penetrate new markets, especially in poor settings. Over.
Yeah, can I add to this extent?
Please.
Can I?
Yes.
Okay. Yeah. So that I mean, the existing tools that we are using for such cases like UReport and Rapid Pro, both is capable of collecting data from the basic mobile phones. So it will largely depend on the person who will be designing these things. So the baseline is that it is very much possible, and the provision is already there in the system.
Thank you, Shah. Final 2 questions. From Rachela. Is it possible to have a partnership with social media founders in order to censor anti-vaccination content?
I'm sorry, Angus is already out in another meeting, but actually our organization, UNICEF, along with other partners, we are into that line. Actually, we have to say that the social media platforms themselves are taking their social responsibility position into this because they are witness and part of this misinformation or disinformation space, and they have to take a stand against that. So there are filters and there are systems that are being developed in that behalf, and UNICEF is into ongoing big partnership with some of them that I cannot expose at this moment, but you will be informed that with our focal points. Maybe Alex wants to add something. Over.
Yes, Ivan, I wanted to add something little. We do have ongoing partnerships with WhatsApp on this. Facebook, I think, is no longer there, but it's something that is being worked upon. And they are working on a number of what we call are known as algorithms to start helping in censoring some of this misinformation. Right now, the best that is available is that if a video is shared or a message is overshared within a border across a number of multiple times or across borders for a number of times or across a number of many groups, that video is reviewed by the WhatsApp and Facebook team. And if it has some of the keywords that have been highlighted by ourselves or other partners or WHO as misinformation, that the ability to share that message is curtailed. So that is what is available for now, but other future developments are coming up and we'll be sharing on them as they come. Thank you.
Thank you very much, Alex and Yvonne. And we have the final question is for Dr. Sidibe. And this is on, are you able to take one last question, Anik? The question asks, based on Burkina Faso experience, to what extent were you able to deal with rumors and disinformation that was emerging on social media? And otherwise, we can respond to this in writing after the call. Okay, I think that we do not have Anik on, so we can close here with the questions. We'd really thank you so much to all of our panelists for your excellent presentations today, to each of the country offices for your collaboration in putting together this PowerPoint. We also like to thank the health unit, the immunization unit, and the C4D unit for collaborating with us on this, along with the digital engagement cell. To all participants, we will share after this call the slides and the recording from this webinar. We'll also share the concept note that Yvonne mentioned and the link to the SharePoint digital health site that Alex mentioned. As you are leaving the call today, you will see an invitation for a quick 3-question survey. Please, we'd love to hear your feedback, especially for the French speakers, your feedback on how the experience was and in general, how we can make our next sessions better. So thank you so much again, everyone, for joining us today, and we look forward to the next session. Thank you all. Have a great day, everyone. Thank you.
Thank you, Irene. Thank you, colleagues. It is